Hi everyone, my name is Rami and I'm going to be talking about systemic immunomodulators in dermatology. I've been wanting to try a flipped classroom approach with pre-recorded lectures for a while now, especially since that would allow people to review the content by re-watching or re-listening to the lecture down the line. And part of the reason I wanted to do that with this lecture in particular is because this content is super high yield. We use immunomodulators all the time in dermatology, both for common diseases like psoriasis and atopic dermatitis, and for less commonly encountered conditions like pyoderma gangrenosum, drug reactions, and graft versus host disease. These medications are your toolbox, your armamentarium. They are the medications you'll have to be able to think of and know about when trying to come up with a plan of treatment for a patient. So this lecture is going to be pretty dense, as we'll discuss mechanisms of action, side effects, monitoring guidelines, indications, and contraindications for each medication, but hopefully having this as a pre-recorded lecture will allow you to view it at your own pace, on your own time, and as many times as you need. The content for this lecture was prepared by combining information from Wolverton, Bologna, and Alicon and Hawker as well. Alright, so let's get started. We'll begin by talking about systemic corticosteroids, then we'll talk about methotrexate, cyclosporine, antimalarials, mycophenylates, azathioprine, apremilast, and IVIg. I'll mention that this is just like a subset of what we use in dermatology. There are a number of other medications that I'm hoping to cover in future lectures, like biologics, including JAK inhibitors, and some other systemic drugs that we use as well, but these I figured were the highest deal, so I want to cover them in this lecture. Okay, so let's start with systemic corticosteroids. The story of corticosteroids begins in 1935, when Kendall discovered compound E, now known as cortisone. The first clinical use was in 1948 for rheumatoid arthritis, and by the 1950s, corticosteroids had revolutionized dermatological treatment. Key milestones include the introduction of alternate day dosing in 1961, which we'll talk about, the use of adjunctive immunosuppressive therapies in the 1970s and 80s, and the development of high-dose pulse intravenous therapy in the 1980s. We'll talk about that as well. Next, we'll talk about the pharmacology of these medications. They're absorbed in the upper jejunum, with 80 to 90% of the medications being bound to cortisol-binding globulin in the bloodstream. They're primarily metabolized in the liver via the CYP3A4 pathway, which we'll talk about, and excreted through bile and feces. The mechanism of action of corticosteroids is complex and multifaceted. They have both genomic and non-genomic effects. Genomically, corticosteroids bind to the cytoplasmic glucocorticoid receptors and form a complex that enters the nucleus and modulates gene transcription and subsequent protein synthesis. Non-genomically, they can induce rapid cellular responses that occur so quickly they can't be accounted for by the genomic effects. They also alter cytoplasmic calcium concentrations and have direct effects on various signaling pathways. Some of the key actions of systemic corticosteroids include suppression of inflammatory cytokine production, such as interleukins 1, 2, and 8, as well as TNF alpha, as well as suppression of key transcription factors in inflammation like NF-kappa B and AP1. They also increase anti-inflammatory cytokines like IL-10, inhibit leukocyte migration, and can directly induce apoptosis in certain cell types like lymphocytes and eosinophils as well. Corticosteroids can be administered orally, intravenously, or intramuscularly. Dosing strategies vary depending on the condition and the treatment goals. We categorize them as short-term bursts lasting 2 to 3 weeks, intermediate-term therapy for 3 to 4 months, and long-term therapy, which should be avoided if possible. Dosage ranges are classified as high, which is over 60 milligrams per day of prednisone equivalent, moderate, which is 40 to 60 milligrams per day, and low, under 40 milligrams per day. Morning dosing is generally preferred to mimic the body's natural cortisol rhythm. When discontinuing therapy, gradual tapering based on clinical response is crucial to avoid adrenal insufficiency. If these medications are used for less than 3 weeks, there's a very low risk of the HPA axis being suppressed, so no taper is needed if you're only doing one of these short courses. Let's take a second to discuss intramuscular Kenalog, or triamcinolone acetonide. While it's a valuable tool in our dermatological arsenal, there are a few key caveats to be aware of. Intramuscular Kenalog, or IMK, has several adverse effects that can develop when it's administered intramuscularly. These include cold abscesses, subcutaneous fat atrophy, crystal deposition, menstrual irregularities, and purpura. Compared to oral corticosteroids, Kenalog offers some advantages. It can improve patient compliance as it doesn't require daily medication, and it's also beneficial in situations where a patient is experiencing nausea or vomiting and may not be able to tolerate oral medications. However, there are also disadvantages. Intramuscular Kenalog tends to cause more HPA axis suppression than oral corticosteroids, and this is because it maintains constant levels throughout the day, and more frequent injections increase this risk. Additionally, it's more challenging to precisely taper the dose compared to oral medications. Given these factors, it's recommended to limit Kenalog injections to no more than 3 to 4 times per year. It's particularly useful for conditions like chronic severe hand dermatitis, which may not be controllable with topicals, or certain autoimmune diseases as well. Next, we'll talk about another option for corticosteroid administration, pulse intravenous dosing. Pulse dose therapy is a powerful treatment option for several severe dermatological conditions. This approach involves administering high doses of methylprednisolone intravenously over a short period. The typical regimen consists of half a gram to 1 gram of methylprednisolone given intravenously over at least 1 hour, repeated daily for 5 consecutive days. This intensive approach is reserved for particularly severe or refractory cases, and some key indications for pulse therapy include severe systemic vasculitis, acute flares of systemic lupus erythematosus, refractory pyoderma gangrenosum, and severe bullous pemphigoid. These are all conditions where rapid and potent immunosuppression is crucial. However, it's important to be aware of the potential serious adverse effects of pulse IV dosing. Cardiovascular complications are a major concern, including the risk of arrhythmias and, in rare cases, sudden cardiac death. Anaphylaxis is another serious risk, as are significant electrolyte disturbances. Neurological complications, particularly seizures, have also been reported. Systemic corticosteroids in general have a wide range of indications in dermatology. They're particularly valuable in treating autoimmune blistering diseases like pemphigus vulgaris and bullous pemphigoid. They're also crucial in managing connective tissue diseases such as lupus erythematosus and dermatomyositis. Other indications include vasculitis, neutrophilic dermatoses, sarcoidosis, and even severe cases of acute contact dermatitis such as to poison ivy. While powerful, it's important to weigh the potential benefits against the risks of side effects of these medications, which we'll discuss next. Systemic corticosteroids come with a significant risk of adverse effects, which can affect multiple organ systems. Endocrine effects include Cushing syndrome and adrenal insuppression. Musculoskeletal complications like osteoporosis and osteonecrosis can occur, especially with long-term use. Cardiovascular effects include hypertension and fluid retention. Metabolically, they can induce diabetes and hyperlipidemia. Dermatologic side effects ironically include skin atrophy, acne, and delayed wound healing. Neuropsychiatric effects like mood changes and insomnia are common. Ocular complications include cataracts and glaucoma. Lastly, corticosteroids increase the risk of infections. Careful monitoring and appropriate preventative measures are essential to minimize these risks. As a bit of an aside, this slide focuses on the different types of corticosteroids used in dermatology and their relative glucocorticoid and mineralocorticoid activities. It's important to note that in dermatology, we aim to harness the glucocorticoid effects of these drugs, while mineralocorticoid effects are generally undesirable due to their potential to cause sodium and water retention and hypertension. We categorize corticosteroids into 3 main types based on their duration of action and their glucocorticoid versus mineralocorticoid activities. Short-acting corticosteroids, like hydrocortisone and cortisone, have lower glucocorticoid activity but higher mineralocorticoid activity. Intermediate-acting drugs such as prednisone, prednisolone, methylprednisolone, and triamcinolone offer a better balance with higher glucocorticoid and lower mineralocorticoid activity. Finally, long-acting corticosteroids like dexamethasone and betamethasone provide the highest glucocorticoid activity with virtually no mineralocorticoid activity. Alternate day corticosteroid dosing, also known as QOD dosing, is a useful strategy that can help reduce the risk of several major complications associated with long-standing corticosteroid use. As the name implies, this approach involves administering the medication every other day rather than daily. By using this method, we can lower the risk of HPA axis suppression, which is a common concern with prolonged corticosteroid therapy, and it can also help to reduce the risk of growth suppression in children, hypertension, opportunistic infections, and electrolyte disturbances. However, it's crucial to note that alternate day dosing does not lower the risk of all corticosteroid-related complications. Specifically, it does not reduce the risk of developing cataracts or osteoporosis. Proper monitoring and management are crucial for safe and effective corticosteroid therapy. According to the textbooks, before starting therapy, baseline assessment should include blood pressure, weight, bone density, blood glucose, lipid profile, and an ophthalmologic examination. Regular monitoring of both clinical response and adverse effects is essential. Preventative measures include calcium and vitamin D supplementation to protect bone health, proton pump inhibitors if needed to prevent gastric ulceration, particularly if a patient is on other medications that can predispose to ulcers, such as NSAIDs like aspirin. Pneumocystis prophylaxis should be given for patients on high-dose therapy, though there's no clear consensus as to what sort of steroid dosing regimen should be accompanied by such prophylaxis. Patient education about potential side effects and necessary precautions is also a critical component of management. By implementing these strategies, we can maximize the benefits of corticosteroid therapy while minimizing risks. The only place I could find any sort of guidelines as to when to start prophylactic medications against the adverse effects of systemic corticosteroids was in the MGH White Book. There, for osteoporosis, they recommended 1,200 milligrams a day of calcium and 800 international units of vitamin D per day if on any dose of steroids for over 3 months. They also recommended considering bisphosphonates for patients who are at intermediate or high risk of fracture. For peptic ulcer disease, they recommended starting a PPI or H2 blocker if the patient is taking aspirin or any other NSAIDs regularly. For PJP prophylaxis, they recommended Bactrim or Dapsone for patients who are on 20 milligrams or greater of prednisone or its equivalent for 4 weeks or longer, who also have a second reason for immunocompromise. Alright, so to summarize, what are some key takeaways about systemic corticosteroids? They work through both genomic and non-genomic mechanisms to suppress inflammation. They can be used in a wide array of dermatologic conditions, but a few key indications include autoimmune blistering diseases, connective tissue diseases, and vasculitis. They should be dosed based on their clinical indication and patient factors, but generally, morning dosing is preferred, and tapering should be based on clinical response. You can also consider alternate day dosing, which can reduce many of the possible complications, and some of these complications include their effects on the endocrine system and the musculoskeletal system, as well as their cardiovascular effects and their metabolic effects as well. For monitoring, you should do baseline assessments, and regular follow-ups are critical as well. Finally, prophylaxis for osteoporosis, peptic ulcer disease, and PJP should be considered in patients who are at high risk for these. Okay, so that's systemic corticosteroids. We'll now move on to methotrexate. Methotrexate is a folic acid analog. It was discovered in the early 1950s for its effectiveness in treating psoriasis, but it took almost 20 years for the FDA to approve it for that. In the 1980s, it was also approved for rheumatoid arthritis. Its use in dermatology has been declining in recent years, but it's still often used in conjunction with TNF inhibitors for psoriasis and rheumatoid arthritis, as it can provide additional immunosuppressive benefit and prevent the development of antibodies that neutralize the TNF inhibitors. Moving on to the pharmacology of methotrexate, it's typically taken orally and it achieves reliable blood levels that are unaffected by food intake. Once ingested, it's widely and rapidly distributed throughout body tissues, with active cellular uptake occurring within the first hour. In the plasma, about half the drug is bound to proteins, with the active portion of the drug being the free fraction or the unbound portion. This is worth noting because any drug that increases the unbound methotrexate portion, such as alcohol, sulfonamides, and salicylates, can increase the risk of toxicity from methotrexate. The kidney excretes the portion of the medication in the plasma within 4 hours, and then the medication is slowly released from tissues back into the plasma over 10 to 27 hours. The primary mechanism of action for methotrexate is the inhibition of dihydrofolate reductase, or DHFR. This enzyme is responsible for converting dihydrofolate to tetrahydrofolate, which is necessary for the synthesis of DNA and RNA components. By inhibiting DHFR, methotrexate affects DNA and RNA synthesis, resulting in the inhibition of cell division. It's important to note that methotrexate doesn't just affect cell proliferation. It also decreases inflammation through multiple pathways, including increasing local tissue concentrations of the anti-inflammatory mediator adenosine. So to put that a little differently, methotrexate blocks purine synthesis, which disrupts DNA and RNA synthesis. It also suppresses antibody responses, reduces T cell proliferation and migration, and as mentioned, increases adenosine production, which has anti-inflammatory effects of its own. When it comes to dosing methotrexate, it's typically administered as a once-weekly dose of up to 30 milligrams for dermatologic and rheumatologic diseases. In dermatology, treatment usually begins with a test dose of 2.5 to 5 milligrams, followed by blood tests to check for any adverse reactions. The dose is then gradually increased by 2.5 to 5 milligrams every 2 to 4 weeks until the desired effect is achieved with minimal toxicity. For psoriasis, the usual weekly dose ranges from 10 to 15 milligrams. Methotrexate can be administered orally, intramuscularly, or subcutaneously, with parenteral administration sometimes preferred for patients who can't tolerate oral methotrexate or when there are concerns about absorption or adherence. Like all powerful medications, methotrexate has a risk of potential side effects that need to be monitored closely. The most significant of these are pancytopenia and hepatotoxicity. Pancytopenia typically develops early in treatment, while hepatic fibrosis and cirrhosis may take years to develop. Other side effects include GI intolerance, the risk of which can be reduced with folate supplementation without any effect on drug efficacy, pulmonary toxicity such as acute pneumonitis, photosensitivity, accelerated rheumatoid nodulosis, and in rare cases, reversible lymphoproliferative disorders. Fortunately, there are a couple options to prevent or treat adverse effects of methotrexate. All patients on the medication, which they take once weekly, should take 1 milligram of folic acid on all other days of the week. You can also give leucovorin or folinic acid as salvage therapy, for example, in patients who develop a severe case of pancytopenia. And this salvage therapy works by bypassing the DHFR enzyme that we talked about earlier. So what are the labs you're going to want to get when starting a patient on methotrexate? You'll want to get a CBC with DIF and a CMP, both at baseline and 5 to 6 days after they take the 2.5 to 5 milligram test dose. You'll also want to check a hepatitis panel and check for TP with either Quant Gold or T-Spot. For patients of childbearing potential, you're going to want to get a pregnancy test, and if a patient has any risk factors for exposure to HIV, you'll want to check that as well. Alright, so what about monitoring for methotrexate? Given its risk of serious side effects like pancytopenia and hepatic toxicity, there are a couple blood tests we're going to want to check every 3 to 6 months, and that includes a CBC and a CMP. Other options for monitoring for hepatic fibrosis or cirrhosis are liver biopsy, which is technically the gold standard, but it's an invasive procedure with its own risks. So there's increasing interest in non-invasive methods of monitoring, including serum markers and imaging studies like the FibroScan and MR elastography. According to the AAD and NPF, a GI consult should be considered for either biopsy or elastography of the liver after the patient has had a cumulative total dose of 3.5 to 4 grams of methotrexate. How do we use methotrexate in dermatology? What do we use it for? So it's FDA approved for psoriasis only, and it's used for severe debilitating or recalcitrant cases. But we also use it for a lot of off-label conditions like dermatomyositis, pityriasis rubopolaris, which often requires higher doses, pleva, bullous pemphigoid, morphia or systemic sclerosis, discoid lupus, systemic lupus erythematosus, vasculitides, atopic dermatitis, and also CTCL like mycosis fungoides. Okay, so those are the indications for methotrexate. What about the contraindications? The only absolute contraindications for methotrexate are pregnancy and lactation. Women are advised to wait at least one ovulatory cycle after stopping the medication before trying to become pregnant, and men should wait at least 3 months after stopping the medication before attempting to get their partner pregnant, as the medication can be found in their semen. And for both sexes, highly effective means of contraception is recommended while on the medication. There are a couple relative contraindications for methotrexate that includes significant liver disease, elevated liver enzymes, patients who excessively intake alcohol, any active infection or immunodeficiency, and any patients with bone marrow suppression for other reasons. And caution should also be taken in patients with renal insufficiency. Lastly, let's discuss important drug interactions with methotrexate. There are several drugs that can elevate methotrexate blood levels, including NSAIDs, salicylates, sulfonamides, phenytoin, and tetracyclines. Dipyridamole and probenecid increase intracellular accumulation of methotrexate. Trimethoprim, sulfonamides, and dapsone inhibit the folate metabolic pathway and markedly increase the risk of pancytopenia when used with methotrexate. Finally, systemic retinoids and alcohol can cause synergistic liver damage when combined with methotrexate. So it's really important to review a patient's full medication list and history before prescribing methotrexate and to educate patients about potential interactions. Alright, so what are the key takeaways for methotrexate? It's a folic acid analog that inhibits dihydrofolate reductase. It's taken once weekly, up to 30 milligrams, but the usual dose for psoriasis is between 10 and 15 milligrams. It can be taken orally or administered intramuscularly or subcutaneously. Some side effects to be aware of are pancytopenia, hepatotoxicity, and GI intolerance. And these can be reduced by supplementing with folic acid on all days on which the medication is not taken. Leucovorin or folinic acid can also be given as salvage therapy, for example, in patients who develop severe pancytopenia as a result of their methotrexate. Patients on the medication should be monitored with regular CBCs and CMPs, and liver biopsy or a non-invasive alternative like FibroScan should be done for patients who are on the medication long term. It's FDA approved for psoriasis, but we use it for multiple other dermatologic conditions. It's contraindicated in pregnancy and lactation and should be used with caution in patients with liver disease or who use alcohol excessively. Key interactions to be aware of are NSAIDs and sulfonamides as well as alcohol, which can all increase the toxicity of the medication. Alright, on to number 3, cyclosporine. Cyclosporine was discovered in 1970 by Borel at the Sandoz laboratory in Basel, Switzerland. It was isolated from a soil fungus, Tolypocladium inflatum gams, during a search for antifungal agents. Although it showed only weak antimycotic activity, in 1976, cyclosporine, also known as cyclosporin A, was identified as a potent immunosuppressive agent. Its therapeutic effects on psoriasis were discovered fortuitously in 1979 by Mueller and Herman during a pilot study investigating cyclosporine efficacy in rheumatoid arthritis and psoriatic arthritis. Cyclosporine has undergone several formulation improvements since its discovery. The original formulation, Sandimmune, was approved for prophylaxis of organ rejection in the United States in 1983. In 1995, Neoral, a more bioavailable and consistently absorbed microemulsion formulation, was approved. Neoral received approval for the treatment of rheumatoid arthritis and psoriasis in 1997. It's important to note that Neoral is the only formulation of cyclosporine approved for psoriasis treatment. It's available as capsules in 25 mg and 100 mg strengths, and as an oral solution containing 100 mg per milliliter. In terms of its pharmacology, cyclosporine is a neutral cyclic peptide composed of 11 amino acids. The Neoral formulation immediately forms a microemulsion in an aqueous environment, leading to better absorption. Its bioavailability is 10% to 54% greater than that of Sandimmune, mainly because neoral is a sort of pre-digested form that's less dependent on bile, food, diet, and gastrointestinal environment for proper absorption. Cyclosporin is extensively metabolized by the cytochrome P453A4 enzyme system in the liver and is primarily excreted via bile through feces, with only 6% of the dose excreted in urine. The mechanism of action of cyclosporin primarily involves T lymphocytes. It forms a complex with cyclophilin, and this complex inhibits the intracellular enzyme calcineurin. This leads to reduced activity of the transcription factor NFAT1, regulating transcription of several cytokine genes, most significantly IL-2. Impaired IL-2 production results in the decline of activated CD4 positive and CD8 positive T cells in the epidermis. Cyclosporin also affects antigen-presenting cells, mast cells, and keratinocytes, and inhibits interferon gamma production, which downregulates ICAM1, reducing lymphocyte infiltration and inflammation. While cyclosporin has numerous applications in dermatology, its only FDA-approved indication is for psoriasis. However, it's widely used off-label for several other conditions. These include atopic dermatitis, which is actually on label in many other countries, pyoderma gangrenosum, chronic idiopathic urticaria, and Stevens-Johnson syndrome / toxic epidermal necrolysis. For psoriasis, cyclosporin is particularly useful for patients with widespread, intensely inflammatory psoriasis or sudden severe flares, and for those who have failed other systemic therapies. How is cyclosporin dosed? For psoriasis, the typical dosage range is 2.5 to 5 milligrams per kilogram per day. The max dose in dermatology is traditionally 5 mg per kg per day, but 4 mg per kg per day should be considered for the neoral formulation due to its greater bioavailability. Cyclosporin is best used short-term, typically less than 6 to 12 months. For obese patients, dosing should be based on ideal body weight, not actual body weight. It's important to start at a lower dose and increase gradually for moderate disease, while severe flares may warrant starting at the maximum dose with subsequent tapering. In general, tapering of cyclosporin should be done gradually. Now let's talk about the major concerns and monitoring requirements for cyclosporin. The primary concerns are nephrotoxicity, which can lead to hypomagnesemia and hyperkalemia, and hypertension, which could be secondary to kidney injury. Hypertension can be managed with calcium channel blockers like nifedipine or isradipine. Long-term use of cyclosporin increases the risk of skin cancer, particularly non-melanoma types. Other effects include hyperlipidemia, hypertrichosis, and gingival hyperplasia. The latter can be improved with good oral hygiene. Patients with a history of gout may experience hyperuricemia and flares of their gout. Neurological symptoms can also occur. Monitoring is crucial. Regular blood pressure checks are essential, and we need to monitor serum creatinine and magnesium levels closely. Lipid profiles should be assessed, and if treatment is needed, fluvastatin is preferred because it doesn't interact with cyclosporin unlike some of the other statins. Importantly, skin cancer screening should be performed regularly as well. So what do we do if we have a patient on cyclosporin and they have a bump in their creatinine? Well, if a patient's serum creatinine rises more than 30% above their baseline level, then we repeat the measurement within 2 weeks to confirm if the elevation is sustained. And if it does remain more than 30% above baseline after the repeat measurement, we reduce the cyclosporin dose by at least 1 milligram per kilogram per day for at least 1 month. After this dose reduction period, we reassess the creatinine levels. There are 2 possible outcomes at this point. If the creatinine decreases to less than 30% above the patient's baseline, we can continue cyclosporin treatment at the new lower dose. However, if creatinine remains more than 30% above the patient's baseline, we can stop cyclosporin treatment entirely. If cyclosporin is stopped, we continue monitoring baseline creatinine levels, and once it's returned to within 10% of the patient's baseline, cyclosporin treatment can potentially be resumed at a lower dose. There are a lot of potential drug interactions when prescribing cyclosporin, most of which are related to medications that have CYP3A4 related metabolism. Several classes of antibiotics can interact with cyclosporin, including macrolides, with erythromycin having a stronger interaction than clarithromycin. Azole antifungals, particularly ketoconazole, can also interact significantly, and other antibiotics to watch out for include aminoglycosides like gentamicin and tobramycin, fluoroquinolones such as ciprofloxacin, and rifampin. Beyond antibiotics, calcium channel blockers like diltiazem and verapamil, as well as HIV-1 protease inhibitors, can interact with cyclosporine. Interestingly, even grape juice can affect cyclosporine levels, which is worth noting because if prescribed as a solution, it's often recommended to mix cyclosporine with some sort of juice to make the flavor more tolerable, but grapefruit juice should be avoided in this situation. Anticonvulsants including phenytoin, carbamazepine, and phenobarbital are another class of drugs that can interact with cyclosporine. CYP3A4 is a crucial enzyme in drug metabolism, accounting for up to half of all drug metabolism. As dermatologists, it's important to be aware of its role and potential interactions. Key substrates relevant to dermatology include cyclosporine, tacrolimus, corticosteroids, and dapsone. And we should be particularly cautious with azole antifungals and macrolide antibiotics, except azithromycin, as these can inhibit CYP3A4 and potentially increase levels of its substrates. Notable CYP3A4 inducers include rifampin, griseofulvin, and some anticonvulsants. These can decrease the effectiveness of CYP3A4 substrates. So to summarize this section on cyclosporine, some key takeaways: it inhibits T cell activation by inhibiting calcineurin, it's metabolized by CYP3A4 in the liver, it's FDA approved for psoriasis, but we use it off-label for other conditions like atopic dermatitis and pyoderma gangrenosum. It's dosed typically between 2.5 to 5 milligrams per kilogram per day for psoriasis, with starting dose based on patient status. When used, short-term use is preferred, typically less than 6 to 12 months. It's dosed based on ideal body weight, and blood pressure, renal function, magnesium should all be checked and monitored while on the medication. The dose should be adjusted if the creatinine rises above 30% of the patient's baseline, and some key adverse effects include nephrotoxicity and hypertension. Next, we'll discuss antimalarials. Antimalarials have a rich history in medicine, dating back to the 1600s, when quinine, derived from the bark of the cinchona tree in South America, was first used to treat malaria. In dermatology, their use began in 1894 when Payne used quinine to treat discoid lesions in lupus erythematosus patients. Today, the most common antimalarials used in dermatology are hydroxychloroquine, known as Plaquenil, and chloroquine, known as Aralen. Quinacrine is also used, but it's only available through compounding pharmacies in the United States. The pharmacology of antimalarials are characterized by extensive tissue absorption and slow release, resulting in a long half-life of 40 to 50 days. This means it can take 3 to 4 months to achieve a steady state and see adequate clinical effects. Hydroxychloroquine is metabolized into 2 primary metabolites, while chloroquine only has 1. Both drugs undergo further metabolism into a primary amine form. Importantly, about half of each drug is excreted through the kidneys. The mechanism of action of antimalarials is complex and not fully understood, but we do know several key effects. These include stabilizing lysosomes within injured cells, inhibiting antigen presentation and cell-mediated immunity, and suppressing the synthesis of pro-inflammatory cytokines. Antimalarials also have antithrombotic and antiplatelet effects. The photoprotective effect, often attributed to these drugs, may be a result of their anti-inflammatory properties. Moving on to the dosing of these medications, most conditions respond to dosages between 200 and 400 milligrams per day of hydroxychloroquine or 250 milligrams per day of chloroquine. The maximum safe chronic dose from an ocular standpoint is 5 mg per kg per day for hydroxychloroquine and 2.3 mg per kg per day for chloroquine based on real body weight. After achieving a therapeutic response, maintenance can often be achieved with lower doses. For patients with porphyria cutanea tarda, much lower doses are required to minimize the risk of toxic reactions. Let's take a minute to discuss quinacrine, an antimalarial drug that can be used in combination with hydroxychloroquine or chloroquine for enhanced therapeutic effect in certain dermatological conditions. One of the key advantages of quinacrine is that it doesn't carry the risk of ocular toxicity associated with the other antimalarials. However, it's important to note that quinacrine has been taken off the market in the United States and now has to be compounded, which can make it challenging to obtain and get insurance coverage for. The typical dosage for quinacrine is 100 to 200 milligrams per day, and it's usually available in 100 milligram tablets. The most serious potential side effect of antimalarials is irreversible retinopathy, although this is rare when dosages remain within the recommended range. Risk factors for retinopathy include high doses, long-term use, especially beyond 10 years, renal impairment, and pre-existing retinal disease. It's important to note that hydroxychloroquine carries a lower risk of retinopathy compared to chloroquine. Regular ophthalmologic monitoring is crucial for early detection of any changes. Monitoring guidelines for antimalarial therapy have recently been updated. The American Academy of Ophthalmology now recommends a baseline ophthalmologic examination within the first year of use. Annual screening then begins after 5 years of continuous use, except for higher risk individuals such as the elderly or those with a history of maculopathy. These patients, along with those experiencing symptoms, should have more frequent screenings. Lab monitoring should also be performed as outlined in Table 130.3 in Bologna. Cutaneous side effects are relatively common with antimalarial use. Up to one-third of patients may develop blue-gray to black hyperpigmentation, typically on the shins, face, palate, or nail beds after just 4 months of use. This discoloration fades after stopping the medication, but may take months to years to resolve completely. Reversible bleaching of the hair roots, called achromatrichia, occurs in about 10% of patients. Various types of skin rashes can also occur. Interestingly, these rashes are more common in patients with dermatomyositis compared to those with lupus. Lastly, antimalarials may worsen psoriasis in some patients. While antimalarials are generally well tolerated, it's important to be aware of some additional side effects beyond the ocular and cutaneous issues we discussed earlier. GI intolerance is the most common reason patients stop taking these medications or require dose adjustments, and this side effect is more frequently seen with chloroquine compared to hydroxychloroquine. Neurologic effects can occur, ranging from restlessness and excitement to more serious issues like confusion, and seizures are a rare but possible complication. Finally, there's a rare but potentially serious risk of bone marrow toxicity. While uncommon, this can be fatal in severe cases. The primary use for antimalarials in dermatology is as a therapy for cutaneous lupus erythematosus. They are particularly useful for patients with widespread discoid lesions and those with annular or papulous squamous lesions of subacute cutaneous lupus erythematosus. In systemic lupus erythematosus, antimalarial use has been associated with fewer thromboembolic events. Antimalarials are only approved for use in systemic lupus erythematosus, rheumatoid arthritis, and antimalarials, but we use them off-label in dermatology for a number of conditions, including autoimmune connective tissue diseases, certain inflammatory skin conditions like lichen planus and its variants, photosensitive disorders, vascular disorders, metabolic disorders like porphyria cutanea tarda, and some other conditions like chronic graft versus host disease. It's particularly useful in disorders with significant lymphocytic infiltrates like lichenoid conditions, lupus paniculitis, polymorphic light eruption, and lymphocytic infiltrate of Jesner. The only true contraindication for antimalarials is hypersensitivity to the drug. However, caution should be exercised in patients with severe blood dyscrasias or hepatic disorders, as bone marrow suppression and hepatitis can occasionally occur. If ophthalmologic changes indicative of premaculopathy develop, an alternative medication should be considered. At this stage, ocular changes are potentially reversible, but could progress if the drug were continued. Regarding use in pregnancy, chloroquine is generally considered safe for treatment and prophylaxis of malaria. However, there have been anecdotal reports of an increase in birth defects in pregnant women being treated for systemic lupus erythematosus. Hydroxychloroquine, therefore, is thought to be safer during pregnancy. Both drugs are excreted in breast milk, but standard doses are not harmful to breastfed infants. The American Academy of Pediatrics approves their use during lactation. There are several important drug interactions that should be considered when prescribing antimalarials. Cimetidine can increase circulating levels of antimalarials, and antimalarials themselves may increase digoxin levels. Over-the-counter gastrointestinal drugs containing kaolin or magnesium trisilicate can decrease the absorption of antimalarials. The most significant potential interaction is the additive risk of retinal toxicity when chloroquine and hydroxychloroquine are used together. Interestingly, in patients with lupus erythematosus, cigarette smoking has been associated with decreased efficacy of antimalarials, though the exact mechanism is unclear. So some key takeaways about antimalarials. Their mechanism of action is incompletely understood at this point. and their dosing is 200 to 400 milligrams per day for hydroxychloroquine and 250 milligrams per day for chloroquine, with a max dose based on the patient's actual weight. There is a rare risk of irreversible retinopathy, and baseline ophthalmologic exams should be conducted within the first year with annual screening after 5 years of use. Hydroxychloroquine is generally preferred over chloroquine in pregnancy, and both are approved for use during lactation. Next, we'll talk about mycophenylates. Mycophenolic acid, or MPA, has been used in various forms for treating psoriasis since the 1970s. However, its use declined until the early 1990s when a more bioavailable and safer version, mycophenolate mofetil, marketed as Celcept, became commercially available. More recently, a newer enteric-coated formulation called mycophenolate sodium, or Myfortic, has also been introduced. Let's dive into the pharmacology of these drugs. Mycophenolate mofetil is highly bioavailable at 94% and is completely converted to MPA after ingestion. MPA is the active form and is 97% bound to albumin in the blood. It's then inactivated to MPAG, which is 82% albumin bound. Over 90% of the drug is excreted in the urine, mainly as MPAG. And it's important to note that in patients with renal insufficiency, plasma concentrations can increase up to 6-fold, which is crucial for dosing considerations. The mechanism of action of MPA is quite specific. It selectively and non-competitively inhibits the enzyme inosine monophosphate dehydrogenase, or IMPDH. This inhibition effectively blocks the de novo synthesis of guanine nucleotides. This action preferentially affects T and B lymphocytes because these cells lack the purine salvage pathway and are dependent on de novo purine synthesis. As a result, MPA decreases immunoglobulin levels, suppresses delayed type hypersensitivity reactions, and inhibits antibody formation by B lymphocytes. When it comes to dosing, mycophenolate mofetil or Celcept is available in various forms: 250 milligram capsules, 500 milligram tablets, and a 200 milligram per ml solution. For dermatologic diseases, the best results are typically obtained with doses of 2,000 to 3,000 milligrams daily taken in divided doses. The newer formulation, mycophenolate sodium or Myfortic, comes in 360 milligram and 720 milligram tablets. Studies have shown that 720 milligrams of mycophenolate sodium twice daily is therapeutically equivalent to 1,000 milligrams of mycophenolate twice daily. As with the other immunomodulators, mycophenolate comes with potential side effects. The most common of these are gastrointestinal, including nausea, vomiting, diarrhea, and abdominal cramps. Interestingly, cutaneous side effects are rare. While uncommon, significant hematologic and hepatic toxicity can occur. In 2008, the FDA released a safety report regarding a potential association between mycophenolate mofetil and progressive multifocal leukoencephalopathy in transplant patients, though this is rare and the cause and effect relationship remains speculative. Regular monitoring is required with mycophenolates, especially of the white blood cell count. Testing should include a CBC and CMP at baseline, and then every 2 to 4 weeks after initiating treatment or escalating the dose, and then every 2 to 3 months once the dose is stable. Before starting the medication, one should also check a baseline hepatitis panel, a TB screen, and pregnancy testing. The dosage should be reduced or therapy discontinued if the white blood cell count falls below 3,500 to 4,000 cells per cubic millimeter. Although mycophenolate is currently FDA approved only for preventing renal allograft rejection, it's found wide use in dermatology for various off-label indications. These include autoimmune bullous disease, severe forms of atopic dermatitis, lichenoid conditions such as cutaneous lupus erythematosus, dermatomyositis, and lichen planus, as well as refractory pyoderma gangrenosum. It's worth noting that mycophenolate is generally used in conjunction with other immunosuppressive drugs, most commonly as a steroid-sparing agent, allowing for reduction in corticosteroid doses. There are a couple important contraindications and precautions to consider when using mycophenolates. The absolute contraindications are pregnancy and an allergy to the drug. Relative contraindications include lactation, peptic ulcer disease, and hepatic, renal, or cardiopulmonary disease. Regarding pregnancy, human data suggests that mycophenolate mofetil may cause birth defects. with a characteristic phenotype including cleft lip and palate and other facial abnormalities. The severity of these defects may depend on the dose, duration, and timing of therapy during pregnancy. Mycophenolate is also contraindicated during lactation due to the potential for immunosuppression in the infant. Finally, let's discuss some important drug interactions with mycophenolates. Drugs that alter the enterohepatic recirculation or GI absorption of mycophenolate mofetil can decrease its effectiveness. These include cholestyramine, iron, and aluminum and magnesium hydroxides. It's also worth noting that when mycophenolate mofetil is used concomitantly with acyclovir, plasma levels of both drugs are elevated. As always, a thorough review of a patient's medication list is crucial before prescribing mycophenolate. Alright, so some key takeaways about mycophenolates. They inhibit IMPDH, blocking guanine nucleotide synthesis and preferentially affecting B and T lymphocytes. Mycophenolate mofetil or Cellcept is dosed at 2 to 3,000 milligrams daily in divided doses, whereas mycophenolate sodium or Myfortic is dosed at 360 to 720 milligrams twice daily. Applications for mycophenolates in dermatology are all off-label, but we use them for psoriasis, atopic dermatitis, bullous dermatoses, autoimmune connective tissue diseases, vasculitides, and lichen planus. Some side effects to keep in mind are GI intolerance and rarely hematologic and hepatic toxicity. Mycophenolates are absolutely contraindicated during pregnancy and have a relative contraindication in lactation. Patients on these medications should be monitored with regular CBCs and CMPs and should have hepatitis and TB testing before starting the medication. Next, we'll talk about azathioprine. Azathioprine was developed in 1959 from its parent drug, 6-mercaptopurine, and it has become a valuable tool in treating inflammatory skin diseases. It offers moderate, immunosuppressive, and anti-inflammatory effects with a reasonable risk-benefit profile. However, due to its potency, it's typically reserved for serious, life-threatening, or recalcitrant dermatoses after other therapies have failed. You may encounter this drug under brand names such as Imuran, Azasan, or Azamune TM. Azathioprine has a high bioavailability at 88%. After absorption, it's immediately converted to 6-mercaptopurine, which then undergoes processing through 3 competing pathways. 2 of these pathways, involving enzymes xanthine oxidase and thiopurine methyltransferase, or TPMT, produce inactive metabolites. The third pathway, via HGPRT, produces active metabolites, including thioguanine monophosphate. It's important to understand that if either of the first 2 pathways is blocked, more 6-mercaptopurine will be processed through the HGPRT pathway, potentially leading to excessive immunosuppression and pancytopenia. The active metabolite 6-thioguanine slowly accumulates in tissues, providing maximal clinical immunosuppression at around 8 to 12 weeks. Let's now talk about the mechanism of action of azathioprine. The primary active metabolite of azathioprine is 6-thioguanine, a purine analog structurally similar to adenine and guanine. Its mechanism of action is multifaceted. Firstly, it incorporates into DNA and RNA, inhibiting purine metabolism and cell division. Additionally, it suppresses T cell function and B cell antibody production. The altered production of antibodies is integral in the treatment of immunobullous dermatoses such as pemphigus vulgaris and bullous pemphigoid. In the skin, azathioprine decreases the number of Langerhans cells and inhibits their ability to present antigens. Let's talk about dosing for azathioprine. It's available in 25, 50, 75, and 100 milligram tablets, and empiric dosing is typically started at 50 milligrams per day and can be increased to a maximum of 2.5 milligrams per kilogram per day based on clinical efficacy and careful monitoring. However, dosing can also be tailored based on the patient's TPMT activity. It's important to note that dose reduction is necessary in patients with renal insufficiency. When starting azathioprine, keep in mind that clinical benefits may not be apparent for 4 to 6 weeks, so patience is key. Regular monitoring of blood counts and liver function tests is crucial throughout treatment. The major side effects of azathioprine are primarily related to its immunosuppressive effects. Pancytopenia can occur, though it's rare when dosing based on TPMT activity. There's an increased risk of malignancies, particularly lymphoproliferative disorders and skin cancers. And a rare but serious concern is a life-threatening hypersensitivity reaction, which typically occurs within the first month of therapy. This reaction can include a morbilliform rash, fever, respiratory and GI distress, hepatotoxicity, and potential cardiovascular collapse. Other side effects include GI upset and hepatotoxicity, and close monitoring is essential to manage these risks effectively. While azathioprine doesn't have FDA approval for dermatologic conditions, it's been used by dermatologists for decades to treat severe skin diseases. It's particularly valuable as a corticosteroid-sparing agent in the treatment of immunobullous diseases like pemphigus vulgaris and bullous pemphigoid, as well as various subtypes of cutaneous vasculitis. It's also been used successfully in treating severe atopic dermatitis and chronic actinic dermatitis. Its relatively low cost and moderate immunosuppressive effects make it an attractive option for long-term management of chronic inflammatory skin conditions. The absolute contraindication for azathioprine is a history of hypersensitivity reaction, as re-challenge can be fatal. Relative contraindications include active serious infections and pregnancy. Special caution is needed when using azathioprine with allopurinol or febuxostat. These drugs can inhibit xanthine oxidase, one of the enzymes that metabolizes azathioprine. If these drugs must be used together, the azathioprine dose should be reduced by 75% to avoid toxicity. Care should also be taken when prescribing azathioprine to patients with a previous treatment history of alkylating agents, as this may increase the risk of adverse effects. Azathioprine was formerly classified as pregnancy category D. It's associated with several risks, including preterm delivery, low birth weight, sporadic anomalies, and hematologic toxicities in the newborn. While it's considered relatively safe for use in transplant patients who become pregnant, for dermatologic purposes it should not be prescribed during pregnancy. Regarding breastfeeding, there are limited data available, but based on several small series, its use is probably allowable during breastfeeding. Azathioprine has several important drug interactions to be aware of. As mentioned earlier, allopurinol and febuxostat can increase the risk of pancytopenia by inhibiting xanthine oxidase. Captopril may increase the risk of leukopenia when used with azathioprine, and azathioprine can decrease the effectiveness of both warfarin and pancuronium, necessitating larger doses of these drugs. It may also decrease the effectiveness of intrauterine contraceptive devices, so alternative birth control methods should be recommended. In some rheumatic disease treatments, azathioprine may be combined with methotrexate, but this is reserved for special circumstances as the combination increases the risk of adverse events. Always review a patient's complete medication list before prescribing azathioprine to avoid potential interactions. Alright, so key takeaways by azathioprine. Its active metabolite is 6-thioguanine, which incorporates into DNA and RNA. It inhibits cell division and suppresses B and T cells. It's typically started at 50 milligrams per day and can be increased up to a max of 2.5 mg per kg per day. Dosing can be based on the patient's TPMT activity. Some side effects of azathioprine include immunosuppression-related complications and rarely pancytopenia. There are no on-label uses in dermatology for azathioprine, and contraindications to the medication include hypersensitivity, and you should be cautious when using it with allopurinol or febuxostat. Finally, it's not recommended for use in pregnancy or breastfeeding, though it's often used in rheumatology, and there's a low rate of passage into breast milk. Okay, almost there. Let's talk about Apremilast. Apremilast, sold under the brand name Otezla, is a novel medication that is a small molecule inhibitor of phosphodiesterase 4. It's administered orally and works intracellularly to modulate the inflammatory response. Specifically, Apremilast reduces the production of pro-inflammatory mediators while increasing those that are anti-inflammatory. This unique mechanism of action makes it a valuable addition to our arsenal of treatments for certain inflammatory conditions. Let's look at the pharmacology of Apremilast. When taken orally, it has a bioavailability of 70 to 75%, reaching peak plasma concentrations in about 2.5 hours. Nearly 70% of the drug binds to plasma proteins. Apremilast is primarily metabolized by the CYP3A4 enzyme, followed by glucuronidation and non-CYP-mediated hydrolysis. It has a terminal elimination half-life of 6 to 9 hours and is excreted in both urine and feces. This pharmacokinetic profile allows for convenient twice-daily dosing. Apremilast's mechanism of action is centered on its inhibition of phosphodiesterase 4, the predominant phosphodiesterase in several key immune cells. This inhibition increases intracellular cyclic AMP levels, which activates protein kinase A. This leads to enhanced expression of transcription factors like CREB while inhibiting others such as NF-kappa B. The downstream effects are significant. It decreases production of inflammatory mediators like TNF-alpha, interferon gamma, and interleukins 2, 12, and 13. Simultaneously, it increases production of the anti-inflammatory mediator IL-10, and it also inhibits natural killer cell responses. The recommended dosage of Apremilast for both psoriatic arthritis and psoriasis vulgaris is 30 mg twice daily. However, to reduce gastrointestinal side effects, an upward titration is recommended. Patients start with 10 mg per day and increase by 10 mg daily until reaching the full dose. Apremilast is available in 10, 20, and 30 mg tablets to facilitate this titration. For patients with severe renal impairment, the maximum daily dose is reduced to 30 mg, and interestingly, no dosage adjustment is necessary for hepatic impairment. As with any medication, Apremilast has its potential side effects. The most common are gastrointestinal, particularly nausea and diarrhea. These are most pronounced during the first 15 days of treatment and typically resolve over several weeks. Headache and nasopharyngitis are also reported. It's important to note that depression, including suicidal ideation, can occur in up to 1% of patients, so those with a history of depression should be monitored closely. About 10% of patients may experience a 5 to 10% weight loss. Interestingly, no routine laboratory monitoring is recommended, but regular weight checks can be performed. Apremilast is FDA approved for two main indications in adults: active psoriatic arthritis and moderate to severe plaque psoriasis. Its efficacy was demonstrated in the ESTEEM trial, where significantly more patients receiving Apremilast achieved PASI 75 and PASI 50 at week 16 compared to placebo. The study also showed improvements in quality of life measures and in nail and scalp psoriasis. Apremilast has also shown promise in several off-label uses. Clinical trials have demonstrated its efficacy in Behçet's disease, particularly in reducing oral and genital ulcers. Small pilot studies suggest potential benefits in discoid lupus erythematosus and lichen planus. There are also individual reports of efficacy in pityriasis rubra-pilaris, vitiligo, and Sapho syndrome, and ongoing studies are exploring its use in various other dermatologic conditions. Apremilast is contraindicated in patients with known hypersensitivity to the drug or its components. As mentioned earlier, dosing should be adjusted for patients with severe renal impairment. And a key precaution to keep in mind is the potential for depression or suicidal ideation. Patients with a history of these conditions should be monitored closely during treatment. The use of Apremilast during pregnancy and lactation requires careful consideration as well. It was formerly classified as pregnancy category C, however there's a lack of well-controlled studies in pregnant women. The current recommendation is to use Apremilast during pregnancy only if the potential benefit justifies the potential risk to the fetus. Regarding lactation, it's currently unknown whether Apremilast or its metabolites are present in human milk. As always, the decision to use this medication in pregnant or breastfeeding women should be made on a case-by-case basis. Finally, let's discuss drug interactions. The primary concern is the co-administration of Apremilast with potent CYP450 inducers. These include medications such as rifampin, phenobarbital, carbamazepine, and phenytoin. These drugs can significantly reduce Apremilast levels in the body, potentially compromising its effectiveness. Therefore, concurrent use of these medications with Apremilast should be avoided. So, the key takeaways on Apremilast. It's a relatively novel oral phosphodiesterase 4 inhibitor marketed as Otezla, and it works by increasing intracellular cyclic AMP levels, which leads to a decrease in inflammatory mediators. The recommended dose is 30 mg twice daily, but it requires initial titration. It's FDA approved for psoriatic arthritis and moderate to severe plaque psoriasis and has shown promise for other dermatologic conditions. Common side effects include GI issues and headache, but notably no routine laboratory monitoring is required. However, caution is needed in patients with a history of depression or severe renal impairment. It's important to avoid co-administration with strong CYP450 inducers as they can significantly reduce Apremilast levels. Finally, let's talk about IVIg. Systemic immunoglobulin therapy has a rich history dating back to the 1960s, when it was first developed for intramuscular injection. In the 1980s, intravenous preparations became available, allowing for broader therapeutic use. IVIg is derived from a purified human plasma pool of more than 1,000 healthy blood donors and contains supraphysiologic levels of IgG. Moving on to the pharmacology of IVIg, it's primarily composed of IgG with small amounts of other immunoglobulins like IgA and IgM. It has a half-life of 3 to 5 weeks and distributes itself throughout the intravascular and extravascular spaces. Importantly, it can cross the placenta and is excreted in breast milk. The metabolism of IVIg is complex and involves the neonatal Fc receptor, which plays a crucial role in extending its half-life. The mechanism of action of IVIg is complex and multifaceted. It works through several key mechanisms. Fc receptor blockade, which can inhibit autoantibody-mediated cellular damage, complement inhibition, which reduces complement-mediated tissue injury, neutralization of autoantibodies through anti-idiotypic antibodies, modulation of cytokine production, and regulation of T and B cell function. This diverse range of effects contributes to its efficacy in various autoimmune and inflammatory conditions. When it comes to dosing and administration, the typical dose of IVIg in dermatology is 2 grams per kilogram per cycle. This is usually divided over 3 to 5 consecutive days. The frequency of cycles is typically monthly, but the duration of treatment varies based on the condition being treated and the patient's response. It's crucial to start the infusion at a slow rate and gradually increase it while monitoring the patient closely for any adverse reactions. While IVIg doesn't have FDA approval specifically for dermatological conditions, it's widely used off-label in our field. The strongest evidence supports its use in dermatomyositis, autoimmune blistering diseases like pemphigus, Stevens-Johnson syndrome, and toxic epidermal electrolysis, and Kawasaki disease. There's also emerging evidence for its use in conditions like atopic dermatitis, chronic idiopathic urticaria, and scleromyxedema. Like any treatment, IVIg can cause adverse effects. Common side effects include headache, fever, chills, myalgia, nausea, and vomiting. These are usually mild and manageable. However, there are rare but serious side effects to be aware of, including thromboembolic events, renal dysfunction, and aseptic meningitis. To avoid these adverse effects, screening and monitoring are crucial. Before starting IVIg, it's important to check for an IgA deficiency, which is associated with a risk of anaphylaxis. It's also worth it to check a rheumatoid factor and cryoglobulins, as presence of these are associated with an increased renal failure risk. You should also consider testing for hepatitis and HIV in patients. Monitoring for IVIg includes checking vital signs prior to, during, and after infusion, as there's a risk of volume overload. You should also check a CBC and CMP after the IVIg. And if the patient is receiving over 2 grams per kilogram, a CBC should be checked at 36 to 96 hours after infusion and again at 7 to 10 days post-infusion to assess for hemolysis. Contraindications for IVIg include IgA deficiency with anti-IgA antibodies, which must be checked for before treatment, and a history of severe reaction to IVIg. Caution should be taken in patients who have renal insufficiency, thrombotic risk factors, a history of fluid volume overload, and if patients are pregnant or lactating. Okay, so to wrap this section up, key takeaways for IVIg. It's composed of purified IgG from over 1,000 donors. Its mechanism of action is complex and multifaceted and has effects on various components of the immune system. It's dosed typically at 2 grams per kilogram per cycle, which is divided over 3 to 5 days. Primary indications for this in dermatology include Kawasaki disease, dermatomyositis, autoimmune blistering diseases, and SJS/TEN. It's relatively safe in pregnancy and elderly, but caution should be taken in these populations. Key side effects of IVIg include infusion-related reactions such as volume overload or anaphylaxis if the patient is IgA deficient, so you should definitely monitor their vitals and check for IgA deficiency before starting the medication, and rarely thromboembolic events can develop. CBC and CMP should be checked before and after IVIg infusion.